I mean, a broken bone is pretty simple, right? It's binary.
Yeah, totally.
You walk into an emergency department with a fractured humerus, they take an x-ray, and, well, there is a jagged white line on a black background. The physician just points to it and says, there's the problem.
Right. It's visible. It's neatly categorized.
Exactly. And for a clinician, that's deeply comforting. But when you step into the world of cardiovascular care, that comforting visibility just completely vanishes.
Oh, it's gone. The X-ray machine is, well, it's basically useless for telling you how well a tissue is actually breathing.
Right. We are looking at a diagnostic landscape that is entirely invisible to the naked eye. And if you miss the subtle external signs of this internal failure today, your patient loses a limb or, their life tomorrow.
It is the absolute definition of diagnostic muddy waters. You're forced to look at the shadows on the wall to figure out what the fire is doing.
Welcome to today's deep dive. If you are listening to this, you are stepping into a really high-stakes clinical arena. Today, we are taking a ruthless, clinical look at current evidence and advanced pathophysiology regarding, one of the most critical concepts in human biology, perfusion.
The big one.
Yeah, it's the fundamental non-negotiable process of blood delivering oxygen and nutrients to every single microscopic tissue in the body. And we aren't just reviewing flashcards today.
No, definitely not.
We are going to deconstruct real-world clinical scenarios, dive into the cellular mechanisms behind the correct answers, and, just as importantly, systematically destroy the flawed clinical reasoning that makes the wrong options so dangerous. I am joined by our resident clinical expert who is going to help us map this incredibly complex terrain.
I am thrilled to be here for this. And, to set the stage for every single scenario we're going to tear apart today, we really must establish one unshakable foundational rule.
Lay it on us.
Impaired perfusion ultimately leads to impaired gas exchange. They are inextricably linked.
Right, because if the blood isn't moving, the oxygen isn't moving.
Exactly. If the arterial blood cannot flow, the oxygen cannot be delivered to the mitochondria, and the carbon dioxide cannot be removed. That makes perfusion the foundational system of the human body.
So without it, everything just stops.
Yeah. Cellular respiration stops, anaerobic metabolism takes over, lactic acid builds up, and the organs simply, they starve to death.
Wow. Okay, so we have to start at the absolute literal end of the line. The very first clinical hurdle is figuring out if blood is actually reaching those distant tissues.
The assessment phase.
Right. Imagine you are standing at the bedside of a new admission. You suspect their peripheral circulation is compromised. You have to definitively assess their tissue perfusion. Now, a novice clinician might look at the study guide options and try to assess their balance with a Romberg test, or maybe check their nail beds for Bose lines.
Or even palpate their chest wall for respiratory excursion.
Exactly, but you need the gold standard. You need to perform a Blanche test. So break down the physiological mechanics of this for us. Why is the Blanche test the true indicator here?
Well, to understand the Blanche test, you really have to visualize the capillary beds. These are the tiniest vessels in the body, right? Only a single cell thick.
Microscopic.
Yeah. So when you press down firmly on a patient's nail bed, you are applying mechanical hydrostatic pressure that actually exceeds the arterial pressure pushing blood into those capillaries.
Oh, I see. You're literally squeezing the blood out.
You're squeezing the red blood cells out of the superficial tissue, causing the nail bed to turn white or blanche. But the critical moment is when you release your thumb.
You're watching for the color to come back.
Right. You're watching how fast that pink color returns. The return of color, which is capillary refill, is a direct, real-time measurement of the arterial pressure's ability to push blood back into the distal periphery against gravity and tissue resistance.
It's a real-time pressure test. I love that. But let's look at why those other clinical observations are dangerous distractors on a study guide. Someone might see a clinician performing a Romberg test and think, oh, they're checking blood flow to the legs.
Right, but the Romberg test is a brilliant diagnostic tool for neurology, not vascular. You have the patient stand with their feet together and close their eyes.
Testing your balance?
Exactly. You are testing the dorsal columns of the spinal cord, which handle proprioception like the brain's awareness of where the body is in space. If they sway or fall, they have a neurological deficit, not a vascular one.
So it tells you absolutely nothing about the volume of oxygenated blood in the calf muscle.
Nothing at all.
Okay, what about those horizontal ridges on the nails? I mean, I see clinicians documenting Bose lines all the time.
Bose lines are fascinating, but they're historical artifacts. They're these deep grooved lines that run from side to side on the fingernail.
And what causes them?
They form when the body suffers a massive systemic shock like, say, a severe infection, malnutrition, or major trauma. The body is forced to temporarily shut down non-essential functions, including making keratin for nail growth.
Ah, so the nail stops growing for a bit.
Right. But nails grow really slowly, so if you see a Bose line halfway up the nail bed, you are looking at a record of impaired perfusion or metabolic crisis that happened, like, 3 months ago.
So it's completely useless for telling you if the tissue is starving for oxygen right this second.
Exactly.
And palpating for respiratory excursion. That was another option.
That evaluates the mechanical symmetry of the chest wall during breathing. You place your hands on the patient's back, have them take a deep breath, and watch your thumbs move apart.
So that's about the lungs, not the blood vessels.
Yeah, it tells you about lung compliance and pleural space integrity. Again, it has nothing to do with the delivery of oxygen to the peripheral tissues. The Blanche test really stands alone.
That structural clarity is what saves lives. Let's stay at the bedside, looking closely at the skin of the lower extremities. Because when you walk into a room, you have to recognize the subtle findings that place a client at massive risk for impaired skin integrity.
Meaning they are about to develop a horrific, non-healing ulcer.
Right. The study guide might try to trick you with options like their feet being warm to the touch or having a rapid capillary refill, but the correct answer, the finding that should make your blood run cold, is faint pedal pulses.
Yeah, that's the red flag.
Connect the macrohemodynamics to the micro-level skin breakdown for us. Why does a weak pulse in the foot guarantee skin destruction?
Well, it all traces back to the metabolic demands of the skin. The skin on the heel and the foot is under constant mechanical stress, from gravity, footwear, the friction of the bed sheets.
It takes a beating.
It really does. So to maintain its structural integrity, the fibroblasts in the skin require a massive, continuous delivery of oxygen and nutrients to synthesize collagen and repair microtears.
The delivery trucks have to keep arriving, basically.
Exactly. And the pedal pulses, specifically the dorsalis pedis on the top of the foot and the posterior tibial behind the ankle, they are your primary indicators of those main delivery routes.
So if those pulses are faint.
If they're faint, it means the arterial pressure traveling down the long pipes of the leg is severely compromised. The blood supply is just trickling. The skin tissues are living in a state of chronic hypoxia.
And without oxygen, cellular repair stops.
Right. The skin thins out, loses its elasticity, and becomes incredibly fragile. The slight friction of a heel dragging across a cotton bed sheet can shear the epidermis right off.
Oh, wow. And because there's no blood flow to bring healing factors, that tiny shear becomes a necrotic ulcer.
Very quickly. And it can reach the bone if you're not careful.
That is terrifying. Let's dissect the other findings, because recognizing normal is just as important as recognizing abnormal. If I palpate the feet and they are warm bilaterally, some might think, oh, that's inflammation.
In the context of perfusion, bilateral warmth is the hallmark of excellent arterial flow. Blood is physically warm. It carries core body heat to the periphery. If the feet are warm, the arteries are wide open and delivering.
Makes sense. And a capillary refill of less than 2 seconds is our normal Blanche test result, right?
Yeah, that proves the microvasculature is intact. Faint pulses are what you need to worry about.
Okay, so we've looked at the very end of the line. Now, we have to look at how we measure the pump itself, because vital sign assessment is where critical errors are made every single day.
Oh, constantly.
Let's say you are measuring an adult client's radial pulse at the wrist, and you notice it's irregular, it's skipping beats. The instinct for a busy clinician is to quickly check the pedal pulses, or grab a Doppler, or just count for 30 seconds and multiply by 2 to stay on schedule.
Which is incredibly dangerous.
Right. The clinical literature dictates that you must immediately abandon the wrist, move to the chest, count the apical pulse for 1 full minute, and describe the rhythm. I want you to defend this. Why is the 30-second shortcut so bad when an irregularity is present?
Because the 30-second shortcut relies on a mathematical assumption of a perfectly symmetrical repeating sequence. When you multiply by 2, you are assuming the next 30 seconds will look exactly like the first 30 seconds.
But the moment you detect an irregular rhythm, that assumption is gone.
Entirely invalidated. Let me give you a mechanical example. Think about atrial fibrillation.
Okay, AFib.
The upper chambers of the heart are quivering instead of squeezing, and the electrical signals are just bombarding the lower chambers chaotically.
So the heartbeat is totally unpredictable.
Right. Some of those ventricular contractions will be strong enough to open the aortic valve and push a pulse wave all the way to the radial artery in the wrist. But many contractions will be too weak.
Ah, so the heart beats, but you don't feel it at the wrist?
Exactly, that's a pulse deficit. If you count at the wrist for 30 seconds during a particularly chaotic flurry of weak beats, you might count like 20 pulses. You multiply by 2 and document a heart rate of 40.
You'd think the patient is severely bradycardic.
Yeah. But if you had listened directly to the apex of the heart with your stethoscope for a full 60 seconds, you would have heard the heart physically contracting maybe 110 times.
So the wrist lied to you.
The peripheral artery always lies during an arrhythmia. You must listen to the mechanical pump itself, the apex, for a full, uninterrupted minute to capture the true rate.
And speaking of identifying rhythms, we have to understand what normal looks like electrically before we can treat the abnormal.
Right, the ECG strip.
Yeah. A normal sinus rhythm is defined rigidly, non-negotiably, by the P wave falling before the QRS complex. Let's take the listener down to the cellular level. Why is this specific sequence the definition of normal?
Well, looking at the macro level, the heart is a two-stage mechanical pump driven by an electrical grid. The P wave on the ECG represents the electrical depolarization of the atria, the two smaller chambers on top.
So they fire first.
They do. The sinoatrial node fires, electricity sweeps across the atria, and they contract, squeezing a final crucial volume of blood, we call it the atrial kick, down into the massive ventricles.
So they are basically priming the main pump.
Exactly. They prime the pump. The QRS complex, which is much larger on the ECG, represents the electrical depolarization of those massive ventricles right before they contract and blast blood out to the body.
So if the P wave does not come first, the mechanical sequence is completely destroyed.
Yeah. If the ventricles fire before the atria, they are pumping an empty chamber. The sequence of P before QRS proves that the sinus node is in command and the pump is being primed correctly.
Now, this rule of the P wave priming the pump applies beautifully to an adult heart. But let's shrink the anatomy and look at pediatrics. Because when you are dealing with an infant, assessing that pump changes entirely.
It really does.
You cannot reliably use the radial pulse. The correct answer on the study guide is you must measure an infant's heart rate at the apex of the heart. Why is the peripheral assessment so flawed in babies?
It's just a matter of anatomical scale and baseline physiology. An infant's peripheral arteries are incredibly tiny, and they're usually buried under a thick layer of subcutaneous brown fat.
The baby fat.
Right. Palpating a microscopic radial artery through baby fat while the child is squirming is nearly impossible. Plus, an infant's normal resting heart rate is already between 110 and 160 beats per minute.
Oh, wow. So it's already racing compared to an adult.
At those speeds, your fingers simply cannot differentiate the pulse waves at the wrist. The apical pulse is the only way to get an accurate count.
And that speed becomes truly terrifying for parents when the infant gets sick. Let's role-play a clinical scenario from the guide. You have a 2-month-old infant brought into the ER with a fever of 40 degrees Celsius, which is 104 degrees Fahrenheit.
That's a high fever.
The parent is staring at the monitor, absolutely terrified, because the infant's heart rate is spiking at 190 beats per minute. Now, the instinct might be to say, "Don't worry," or "We'll give medicine to slow the heart down." But the correct therapeutic communication is simply, the fever is causing an increase in your baby's heart rate.
Yes, that is exactly right.
Break down why this direct physiological truth is the ultimate anxiety reducer. Why not just reassure them?
Because parents in the ER are terrified of the unknown. An alarm going off in a heart rate of 190 looks like a catastrophic failure of the heart.
Oh.
If you offer platitudes like "don't worry," you instantly lose their trust because they should be worried.
Their child is sick.
Right. By stating, "the fever is causing an increase in your baby's heart rate," you perform an immediate, crucial piece of medical translation. You connect the symptom they understand, the fever, to the terrifying number on the screen.
So explain the thermodynamics to us. Why does the fever drive the heart rate so high?
It's basic metabolic thermodynamics. For every single degree Celsius of temperature elevation, the body's metabolic demand skyrockets by about 10 to 12%.
Wow, that's a huge jump.
It is. The infant's immune system is fighting a massive war, and generating that 104-degree heat requires an immense amount of cellular energy. All those cells suddenly demand massively increased deliveries of oxygen.
And the baby's heart can't just pump harder like an adult's.
No, an infant's heart cannot significantly increase its stroke volume. Their heart muscle is too small and stiff. So the only compensatory mechanism the infant has to meet that oxygen demand is to pump much faster.
So the heart isn't failing, it's doing exactly what it's supposed to do to keep the baby alive.
Precisely. When you explain that underlying why to the parent, It transforms the number on the monitor from a sign of failure into a sign that their baby's body is fighting back.
That is the power of understanding the mechanism. Okay, we spent a lot of time looking at how we assess the system at baseline. Let's transition into the setup for cardiovascular disease, the risk factors and lifestyle choices that slowly destroy the plumbing.
This is the era of preventive medicine, really.
Let's start with demographics, because risk is not distributed equally. The clinical data is clear. African Americans are the population at the greatest risk for impaired perfusion and cardiovascular disease.
It is a profound demographic disparity, and it stems from a highly complex intersection of factors. Genetically, there is a higher prevalence of salt-sensitive hypertension within this population.
Meaning their kidneys hold on to sodium more aggressively.
Exactly, which expands blood volume and drives up arterial pressure. But you absolutely cannot separate the genetics from the systemic environmental factors. We are talking about chronic stress from systemic racism, which keeps the sympathetic nervous system locked in fight or flight.
And food deserts, too.
Yes, living in food deserts where high-sodium, ultra-processed foods are the only accessible options. Recognizing this multifaceted risk is the first step in culturally competent prevention.
Prevention requires knowing your enemy. Let's look at a community presentation scenario. You have to outline the modifiable risk factors for atherosclerosis. The correct answers are smoking, a sedentary lifestyle, a high-fat and high cholesterol diet, and obesity.
The classics.
Right. But patients hear these words so often they lose all meaning. I want you to explain how these 4 specific factors work together to brew a perfect, localized storm inside a single artery.
Okay, to understand atherosclerosis, visualize the tunica intima, that incredibly delicate single-cell inner lining of your blood vessels. It is supposed to be perfectly smooth, like Teflon, so blood cells glide past.
Okay, Teflon coating. Got it.
Let's start with smoking. The chemicals in cigarette smoke enter the bloodstream and act like microscopic sandpaper. They physically and chemically shred that delicate Teflon lining, creating jagged microtears and sparking severe inflammation.
So now the pipes are damaged and sticky.
Right. Now introduce the high-fat, high-cholesterol diet. You are flooding the bloodstream with excessive LDL cholesterol. Because the vessel lining is damaged and sticky, those LDL particles don't just float by, they get trapped in the microscopic tears.
And the body tries to fight that, right?
Yes, the immune system sees this trapped cholesterol as an invader, sends in macrophages to eat it, and they die, forming toxic, fatty streaks called foam cells.
So we have a sticky, damaged pipe actively filling with toxic fat. Where do the sedentary lifestyle and obesity come in?
Well, a sedentary lifestyle means your heart rate is constantly low and your blood flow is sluggish. It's like a slow-moving river. Debris has plenty of time to settle on the banks.
Ah, so more time for cholesterol to stick.
Exactly. And obesity acts as a massive metabolic multiplier. Visceral belly fat is an active endocrine organ that constantly pumps out inflammatory cytokines into the bloodstream, keeping that vessel wall perpetually inflamed.
Accelerating the whole process until the artery is completely blocked? Terrifying. So how do you actually intervene? Let's say you have a female client who smokes, has hypertension, and a BMI of 26. The correct goal-setting answer is walk for 30 minutes, 5 days a week.
Yes, that is the gold standard of early intervention.
But why? Why not focus on the smoking first? She's smoking a pack a day.
Because smoking cessation, while critical, has a massive failure rate and often triggers intense anxiety and weight gain, which can discourage the patient. You need an intervention that is highly actionable and provides immediate compounding benefits.
So what exactly is happening in her arteries when she walks?
First, the physical shear stress of the increased blood flow over the endothelium forces the vessels to release nitric oxide, which is a potent natural vasodilator. This helps immediately lower her hypertension.
Oh, natural blood pressure meds.
Exactly. And most importantly, routine aerobic exercise forces the body to build new, tiny blood vessels capillaries in the muscle tissue, a process called angiogenesis. You are literally building a bigger, more efficient circulatory network.
It's the perfect foundational goal. But let's transition from the sidewalk to the kitchen. Dietary interventions are notoriously tricky. Let's look at a scenario. A patient with atherosclerosis proudly says, I eat 2 eggs for breakfast each morning.
Oh boy.
As a clinician, you need to provide further teaching here. Now, patients hear high protein on podcasts and think eggs are a superfood. Why is this patient actively accelerating their disease?
It comes down to the density of the specific lipids they are consuming. Yes, the egg white is pure protein, but the yolk of a single large egg contains roughly 186 milligrams of dietary cholesterol.
And what's the limit?
The absolute maximum recommended daily limit for a healthy person is 300 milligrams. For someone with established atherosclerosis, the American Heart Association recommends staying well under 200 milligrams a day.
So they are blowing past their limit before 8:00 a.m.
Exactly. Their liver cannot process nearly 400 milligrams of dense cholesterol fast enough, so it gets packaged into LDL particles and circulated through the body, where it will inevitably find its way into the plaques, narrowing their arteries.
Let's look at another dietary red flag from the study guide. A hypertension patient says, I may eat 10 ounces of lean protein each day. Again, lean protein sounds healthy. What's the hidden danger here?
The danger lies in the sheer volume and the immense metabolic load it places on the kidneys. 10 ounces of meat in a single day is a massive amount of animal tissue. Digesting that much dense protein generates a massive amount of nitrogenous waste, specifically urea, which the kidneys have to filter out.
And their kidneys are already damaged from the high blood pressure.
Right. Hypertension causes hardening of the tiny filtering arterioles inside the kidneys. Forcing them to filter the waste from 10 ounces of animal protein every day acts like pouring sand into a struggling engine.
So what does a correct choice look like? Let's say a patient is recovering from a coronary artery bypass grafting. If they are handed a menu, choosing beans reflects a perfect understanding of a low cholesterol diet.
Beans are the unsung heroes of cardiovascular nutrition. They contain absolutely 0 milligrams of cholesterol. Furthermore, beans are packed with soluble fiber, which physically binds to circulating cholesterol in the digestive tract and drags it out of the body in the stool.
Before it even reaches the bloodstream.
Exactly. It's a proactive, protective food.
Let's quantify exactly what we're trying to protect the body against. A male client gets his routine lab work back. His LDL comes back at 172 milli-GDL. Put that number into physiological context.
That number places him firmly in a highly dangerous clinical zone. LDL is the lethal cholesterol. We want that number strictly below 100 and optimally below 70 in patients with risk factors. At 172, his bloodstream is supersaturated.
When these risk factors are ignored, the pressure inside the vessels begins to rise relentlessly, which brings us to the silent killer, hypertension.
Hypertension is the mechanical stressor that slowly dismantles the entire vascular system from the inside out.
Let's get our diagnostic numbers straight. A client's blood pressure is measured at 124/84. The clinical guidelines categorize this strictly as pre-hypertension.
The parameters are rigid for a reason. Normal blood pressure is strictly less than 120 systolic and strictly less than 80 diastolic. The moment you hit that 120 to 129 systolic range, you have crossed the threshold into pre-hypertension.
It's a massive warning light, and the causes of this pressure can be incredibly hidden. The study guide highlights obstructive sleep apnea, or OSA, as a key risk factor for developing hypertension. Why does snoring cause high blood pressure during the day?
The mechanism is fascinating and terrifying. When a patient with OSA falls asleep, the soft tissues in the back of their throat collapse, completely blocking the airway. They stop breathing.
So their oxygen drops.
Their oxygen saturation plummets, and their carbon dioxide spikes. The chemoreceptors in their brain sense this asphyxiation and trigger a massive, desperate, sympathetic nervous system response, a colossal surge of adrenaline to jolt the brain awake just enough to gasp for air.
So they're getting hit with like an EpiPen's worth of adrenaline while they sleep.
Exactly. Right while they sleep. And this happens dozens, sometimes hundreds of times every single night. Adrenaline causes profound peripheral vasoconstriction. Over months and years, this constant mechanical trauma causes the blood vessels to lose their elasticity.
They become rigid pipes.
Yeah, and because the pipes are now permanently stiffened, the patient's baseline blood pressure stays dangerously high 24 hours a day.
This highlights why screening is so vital. Let's look at a health fair screening protocol. You measure a client's BP, and it reads 150/90. Now, the incorrect options are sending them to the ER or telling them to wait 6 months. The correct action is giving the client a written record to bring to their provider.
Yeah.
Defend this. Why not the ER? 150/90 is objectively high.
It is high, but we must differentiate between chronic pathology and an acute crisis. A true hypertensive emergency typically involves a systolic pressure well over 180, accompanied by acute signs of end organ damage, like sudden chest pain or neurological deficits.
So sending them to the ER just clogs up the waiting room.
Exactly. But why not wait 6 months? Because a pressure of 150/90 is causing microscopic damage to the endothelium, the retinas, and the kidneys every single minute. 6 months is an eternity in vascular time.
So you give them the written data to take to primary care. Now, if they do get a diagnosis of essential hypertension, what specific physical manifestation must you actively monitor for? The literature points directly to vertigo.
Vertigo, a profound sensation of spinning or dizziness, is a critical warning sign. The microvasculature inside the inner ear is incredibly delicate. When the systemic arterial pressure is excessively high, it disrupts the normal fluid dynamics of the inner ear, leading to acute vertigo.
It's a sign the pressure is compromising neurological function. Dealing with this brings massive anxiety. Let's look at the communication aspect. A client is terrified to take his BP medication. The instinct is to list the medical benefits, but the study guide says the correct response is reflection. You seem upset about taking your blood pressure medication.
Yes, because you cannot educate a patient whose brain is locked in a state of emotional paralysis. When a patient is terrified, their prefrontal cortex, the logical, learning part of the brain, is effectively shut down.
If you start lecturing them, they just feel attacked.
Exactly. Reflection acts as an emotional mirror. By saying you seem upset, you are objectively observing and validating their emotional state. It creates a safe space for them to reveal the root cause of their fear. Maybe they can't afford it and are ashamed to admit it.
It's about treating the human first. Let's look at professional communication. You're using the SBAR framework to call a physician about an HTN patient with sudden drooping facial features. Where does the history of HTN belong in the report?
It belongs unequivocally in the background component.
Because the situation is the facial drooping.
Right. The physician's brain immediately jumps to stroke, but they need context. By stating in the background, the patient has a history of uncontrolled hypertension, you provide the pathophysiological context that confirms their suspicion.
Here is a complication of cardiovascular disease that most people would never think of. Straining while defecating can cause dangerous dysrhythmias in older adults. Break down the biomechanics of this. How does sitting on the toilet trigger a heart attack?
It's a terrifying cascade centered around the Valsalva maneuver. When an older adult bears down to defecate, they take a deep breath, close their glottis, and push. This massively increases the physical pressure inside their chest cavity.
They turn their chest into a pressure cooker.
Exactly. That massive chest pressure physically collapses the superior and inferior vena cava, the veins bringing blood back to the heart. Cardiac output drops to near zero, and blood pressure plummets.
And the brain panics.
It screams at the brain that the patient is bleeding out, triggering a massive adrenaline dump. But then they exhale and release the strain. The pressure instantly vanishes, and all that blood comes crashing back into the heart like a tidal wave.
While the heart is flooded with adrenaline.
Yes, and at the exact same time, the physical act of straining stimulated the vagus nerve in the abdomen, which tells the heart to stop beating. So you have a fragile heart flooded with blood, screaming with adrenaline, and simultaneously being ordered to drop its rate.
That conflicting chaos causes a lethal dysrhythmia. Horrifying. We have to bring the pressure down. Let's enter the pharmacy. Diuretics are the first-line medication for hypertension. Why diuretics?
Because before we attempt to force the rigid blood vessels to dilate, we can easily decrease the physical volume of fluid rushing through those rigid pipes. Diuretics force the kidneys to excrete sodium, and water follows sodium. Less fluid in the pipes equals less pressure.
The classic diuretic is hydrochlorothiazide. The key instruction is to take it early in the day. I'm assuming this is to avoid nighttime urination.
It is, but it's really a matter of physical safety. If a patient takes this pill at 8 takeovable p.m., they will be forced out of bed every hour to urinate.
Which destroys their sleep.
Yes, but more dangerously, you have an older adult with artificially lowered blood pressure standing up quickly in the dark. Orthostatic hypotension, combined with urgency in the dark, is a guaranteed recipe for a catastrophic hip fracture.
It must be taken in the morning. Let's move to captopril, an ACE inhibitor. Two maybe points here. First, do not use salt substitutes. Why are salt substitutes lethal with captopril?
Captopril inhibits the ACE enzyme, which eventually stops the production of aldosterone. Without aldosterone, the kidneys dump sodium but aggressively hold on to potassium.
So their baseline potassium levels rise.
Right, and commercial salt substitutes are almost entirely made of potassium chloride. If a patient who is already hoarding potassium pours a pure potassium substitute on their food, their serum potassium levels will skyrocket, leading directly to a fatal cardiac arrest.
And the second point. Captopril is associated with a bothersome, non-productive cough.
The infamous ACE-KEys. The ACE enzyme is also responsible for breaking down an inflammatory peptide called bradykinin in the lungs. Because captopril disables the enzyme, bradykinin accumulates, triggering a dry, hacking cough.
It's an expected side effect, not an allergy. Let's look at atenolol, a beta blocker. Monitor for the adverse effect of bradycardia.
Atenolol blocks the receptors on the heart that normally receive adrenaline. It forces the heart to beat slower with less force. But if the dose is too high, the heart rate can plummet dangerously low bradycardia, depriving the brain of oxygen.
Finally, verapamil, a calcium channel blocker. Instruct the client to strictly avoid taking this with grapefruit juice. Is the acid in the grapefruit destroying the drug?
It has absolutely nothing to do with the acid. Grapefruit juice contains compounds called furanocoumarins. They aggressively bind to and completely disable a specific metabolic enzyme in the liver known as CYP3A4.
And that enzyme breaks down the verapamil.
Exactly. If the patient drinks grapefruit juice, the enzyme is knocked out. The verapamil is absorbed, but it cannot be broken down. It rapidly accumulates to massive, highly toxic levels, resulting in profound hypotension and lethal cardiac blocks.
A single glass turns a therapeutic dose into an overdose. Phenomenal breakdown. We've seen how hypertension damages the system centrally, but now we have to look at what happens in the distant extremities, peripheral arterial disease, or PAD.
Tracing the damage away from the heart.
Let's start with early-stage PA. The classic symptom is intermittent claudication pain with movement. Walk me through the cellular environment of the calf muscle when this happens.
In early-stage PA, the main arteries feeding the legs are narrowed by plaque. When the patient is resting, the trickle of blood is enough to supply oxygen for basic metabolism.
But then they stand up and try to walk.
The moment they engage those muscles, the demand for oxygen skyrockets. But the rigid blocked artery cannot dilate. The muscle cells are starved of oxygen and are forced to switch to anaerobic metabolism, which builds up lactic acid.
And lactic acid burns.
It physically burns the nerve endings, causing excruciating cramping pain. But when they sit down, the demand drops, the lactic acid clears, and the pain stops. Intermittent claudication.
But the disease progresses. An assessment of a client with advanced PAD reveals leg pain at rest. Why does this shift indicate a terrifying acceleration?
Resting pain means the blockages are so severe that the trickle of blood is no longer enough to sustain the tissue even when the patient is sitting completely still. The cells are constantly starving.
And this often happens at night, right, because they lose gravity.
Precisely. When they lie flat, gravity is neutralized. The weak arterial pressure cannot overcome the resistance of the blockages horizontally. The nerves misfire constantly, causing agonizing pain. Amputation is looming.
So how do we intervene? To promote comfort for a PA patient with cold feet, the right answers are: obtain slipper socks, adjust the thermostat so the room is warm, and incorporate walking into their daily routine.
The slipper socks and warm room target the vasomotor center. Cold environments trigger vasoconstriction. By keeping the feet warm, you manually relax the smooth muscle in the arteries to keep the plates as wide open as anatomically possible.
But why prescribe walking if it triggers their excruciating pain?
Because it relies on collateral circulation. When a patient walks to the point of ischemic pain, the starving muscle cells release vascular endothelial growth factor, or VEGF. VEGF literally forces the body to sprout brand new microscopic blood vessels that detour around the blockages.
The body builds its own bypasses. That is incredible. Let's look at the venous side. Deep vein thrombosis. A postoperative abdominal surgery patient is assessed. The key finding is unilateral leg edema. Why is unilateral swelling the critical diagnostic key?
Because if a patient has bilateral edema, both legs swollen symmetrically, it tells you the main pump, the heart, is failing systemically. But if only one leg is swollen, the systemic pump is fine.
There's a localized problem.
Right. A massive blood clot, a DVT, is formed in the vein of that one leg. The arterial blood pumps down, but it cannot return through the blocked vein. The pressure skyrockets, forcing plasma into the tissue, causing it to swell tight like a balloon.
We've looked at the pipes. Now, what happens when the central pump fails? Heart failure. The heart is actually two separate pumps. Let's start with left-sided heart failure. If the left side fails, where does the blood go?
The left ventricle blasts blood out to the entire body. If it fails, the blood backs up into the left atrium and from there directly into the lungs.
So the findings are respiratory: hacking cough, breathlessness, dyspnea, and frothy sputum in older adults. Explain the frothy sputum.
The pressure forces liquid plasma straight through the alveolar membrane into the air sacs. The lungs are literally filling with fluid from the inside out. As they breathe, it whips the proteins into a pink, mubbly foam.
They are drowning on dry land. And even a toddler with HF will present with orthopnea, shortness of breath, while lying down.
Yes, because when you lie flat, you neutralize gravity. All the fluid in your legs races back into your central circulation. A failing left ventricle is overwhelmed by the sudden volume, and it instantly backs up into the lungs.
So the immediate action for a client having difficulty breathing is to place them in Fowler's position. Sit them straight up to use gravity to pull the fluid out of the chest. Contrast that with right-sided heart failure.
The right ventricle pumps blood to the lungs. If it fails, it backs up into the massive veins, returning blood from the entire body.
So the expected findings are peripheral edema and hepatomegaly enlarged liver.
Yes, the liver is a massive vascular sponge connected to the inferior vena cava. The immense venous pressure is transmitted directly down into the liver, swelling it to sometimes twice its normal size.
Discharge teaching for congestive heart failure. A client says, I plan to slow down if I am tired the day after exercising, and they plan to exercise 3 times per week. Why exercise a failing heart?
By exercising mildly, the patient trains their skeletal muscles to become highly efficient at extracting oxygen. If the muscles are efficient, the heart doesn't have to pump as much volume. You condition the periphery to save the pump.
But they have to stop if they're tired the next day because they pushed past their compensation threshold. Let's look at the heart failure pharmacy. Furosemide, a loop diuretic. You must monitor serum potassium closely.
Furosemide paralyzes the pumps in the kidney that reabsorb sodium. Water follows the sodium out into the urine, but the kidney panics about losing so much sodium, so it activates a different pump that sacrifices potassium to try and save the sodium.
The potassium is flushed out, which leads to the adverse effect, leg cramps.
Exactly. When serum potassium drops dangerously low, the resting membrane potential of muscle cells becomes unstable. The calf muscles will spontaneously lock into a violent spasm.
A clinical scenario. A client has a potassium level of 2.4 MEQL. You must identify furosemide as the direct cause, and if a patient's K is 2.8, you must absolutely withhold medication.
A normal potassium is 3.5 to 5.0. At 2.8, they're in profound hypokalemia. Their heart is electrically unstable. If you give more furosemide, you will chemically induce a lethal cardiac arrest.
The guidelines also mention bumetine's same rules, notify provider for K of 2.3. But then there's spironolactone. It puts clients at risk for both hyperkalemia and hyponatremia. Why does it trap potassium while the others flush it out?
Spironolactone is a potassium-sparing diuretic. It blocks the receptors for aldosterone. Aldosterone tells the body to retain sodium and excrete potassium. By blocking it, spironolactone forces the kidney to do the exact opposite: dump sodium and rigorously hold on to potassium.
So what happens during a high potassium crisis? A client has a potassium of 6.8. The immediate action is to obtain a 12-lead ECG. Why are we running for the ECG before giving meds?
Because high potassium is just as lethal as low potassium. It lowers the resting membrane potential, making the cardiac cells prone to fatal heart blocks.
You need to see the electrical tracing to know how close they are to a flat line.
Exactly. The ECG dictates whether you have 30 minutes to give a binding resin or 30 seconds to push intravenous calcium gluconate to stabilize the tearing heart muscle.
Let's talk about digoxin, used for left-sided heart failure and atrial fibrillation. Pre-administration, the priority lab to check is potassium. Hypokalemia increases the risk for digitalis toxicity.
This is a deadly trap. Digoxin and potassium compete for the exact same receptor sites on the heart cells. If the patient's potassium drops too low, there's no competition. The digoxin grabs every single receptor, and its effects are exponentially magnified.
Low potassium turns a normal dose into an overdose. What are the toxicity signs? Nausea, vomiting, anorexia, and blurred vision, specifically seeing yellow halos.
Yes. If a client on 0.25 milligrams daily refuses breakfast and reports nausea, your first action is to check vital signs, specifically the apical pulse for 1 full minute.
If the heart rate has plummeted to 42, you have a complete picture of acute toxicity. And a quick interaction note. Instruct the client to avoid the herbal supplement St. John's wort.
St. John's wort forces the liver into hyperdrive, rapidly metabolizing and destroying the digoxin. The drug levels drop, throwing the patient back into heart failure.
Heart failure is a chronic struggle, but sometimes there's a sudden catastrophic blockage, the myocardial infarction.
A heart attack. The coronary arteries become completely occluded by a ruptured plaque and a blood clot.
Manifestations: substernal chest pain, nausea, tachycardia, diaphoresis. But the study guide notes an 85-year-old may simply present with acute confusion. Where did the chest pain go?
Their aging nervous system can't mount the massive adrenaline response, and neuropathy might dull the pain signals. Instead, as the heart stops pumping, their cardiac output crashes, depriving the brain of oxygen. The first sign is profound confusion.
Angina versus MI. How do you tell the difference?
Angina is temporary ischemia. When the patient rests, the oxygen demand drops and the pain completely subsides. An MI is a 100% total occlusion. Sitting down does absolutely nothing because blood flow is zero.
Triage scenario. A train collision. Who gets the single resuscitation day? Patient A with neck pain on a backboard, patient B with epigastric and left arm pain and diaphoresis, patient C with nasal ecchymosis, or patient D with abdominal pain 2 months pregnant.
Patient B is actively dying right in front of you.
Because patient A is already stabilized on the backboard, patient D needs an ultrasound but isn't showing signs of shock. Patient C just has a bruised nose.
Right. Patient B is the trap. The epigastric pain radiating down the arm with sweating is the textbook presentation of an acute MI. The stress of the crash ruptured a plaque. They need that bed.
To determine if it's an MI, the first action is a 12-lead ECG. You are looking for elevated ST segments.
An elevated ST segment proves that a full-thickness infarction is happening right now. Massive amounts of potassium leak out of dead cells, altering the electrical gradient and pulling the ST segment upward.
Lapsed troponin I is elevated 3 hours post-MI. What does it show?
Troponin is a protein locked inside myocardial cells. The only way it ends up in the blood is if a heart muscle cell bursts open and dies. The higher the number, the more cells have died.
Cardiac enzymes determine the degree of damage, but not the location. To contrast, the MI, an expanding abdominal aortic aneurysm, or AAA, is indicated by reports of sudden, severe back pain.
The aorta is ballooning outward. If it expands rapidly, it puts agonizing physical pressure on the spinal nerves of the lower back. It means the pipe is about to burst.
MI interventions. First prescription to initiate is oxygen therapy. Why?
You must maximize the efficiency of whatever tiny trickle of blood is still getting past the clot. High-flow oxygen supersaturates the red blood cells, buying you time.
Nitroglycerin. The client takes it, gets pain relief, but now has a headache. Is this an allergy?
No, it's an expected adverse effect. Nitroglycerin dilates blood vessels systemically, including in the brain. The rush of blood into the skull causes a massive headache. Don't stop the med, just give an analgesic.
Aspirin, 325 milligram, is given for its antiplatelet aggregate action. It stops the platelets from clumping and growing the clot.
Yes. And morphine is administered to manage pain and anxiety. Pain drives panic, which drives adrenaline, which massively increases the heart's oxygen demand. Morphine slows the heart and drops the oxygen demand.
Post-MI complications. Death following NMI is often a result of dysrhythmias in the first 24 hours.
The tissue bordering the dead zone is irritable. The electrical pathways are disrupted, triggering ventricular tachycardia or fibrillation. That's why they're on continuous monitoring.
Older adults are highly prone to complications because peripheral vascular resistance increases with age. The vessels become rigid pipes, and the damaged heart tires out pushing against that high resistance.
Exactly.
After a PTCA with stent placement, the care plan must include monitoring for bleeding.
The cardiologist punctures a massive artery in the groin or wrist and pumps the patient full of anticoagulants. If the puncture site tears, they can hemorrhage lethally in minutes.
Acute post-MI crisis. 5 days later, the client has sudden shortness of breath and coughs frothy pink sputum. The nurse auscultates loud, bubbly sounds on inspiration, documented as coarse crackles.
This is delayed mechanical consequence. The healthy muscle is exhausted from compensating and finally fails. The blood backs up into the lungs. The coarse crackles are the sound of air popping through the fluid flooding the airways.
Psychosocial care. If a client on telemetry says, "All this equipment is making me nervous," the best response is validation. All of this equipment can be frightening.
Validation builds immediate trust. It lowers their sympathetic tone and calms the heart.
And if they doubt their ability to maintain a low cholesterol diet, what about the low cholesterol diet concerns you?
Use open-ended questions to find the specific barrier. You cannot fix the adherence problem until you illuminate the root cause of their anxiety.
Finally, the blood itself, anemias. What happens when the delivery vehicles are deficient? Blood loss during surgery manifests as dyspnea on exertion.
The brain senses profound hypoxia the moment they exert themselves and makes the lungs work twice as fast to load the few red blood cells that are left.
Pernicious anemia is caused by vitamin B12 deficiency, often following a total gastrectomy.
The stomach secretes intrinsic factor, which is required to absorb B12. If you remove the stomach, you remove the intrinsic factor. The B12 just passes right through them.
The Schilling test measures the ability to absorb B12, and the treatment is dietary supplements of vitamin B12.
But not oral pills. It involves deep intramuscular injections, completely bypassing the gastrointestinal tract.
Iron deficiency anemia. The client takes ferrous sulfate twice a day. You must instruct them to take the medication with orange juice.
Oral iron is notoriously difficult to absorb. The vitamin C in orange juice chemically reduces the iron into a form that is incredibly easy for the intestines to pull into the bloodstream, massively increasing its bioavailability.
We have meticulously assessed the capillary beds, navigated lifestyle risks, wrestled with hypertension, balanced heart failure pharmacology, survived an MI, and looked at the red blood cells.
It's a brilliantly complex system, and it requires immense clinical reasoning to safely manage when that symphony begins to fail.
I'm going to pass it over to our expert to leave you with one final thought to ponder.
The human cardiovascular system is brilliantly adaptable. It will do anything to survive a crisis. But think about this. How does our increasingly sedentary, hyper-processed modern lifestyle force our hearts to permanently live in a state of desperate emergency compensation? And what happens when those temporary, life-saving physiological adaptations simply become our baseline normal?
Thank you for joining us on this rigorous deep dive.